Thank you to the organizers and Hari for the invitation to speak at this session. There we are. Good. And you'll reset this timer so this red light doesn't keep blinking at me. Thank you. I'm going to talk about consolidation maintenance for multiple myeloma patients. These are my disclosures, consultations, and also discussion of multiple off-label therapies. This is Roswell Park. This is Roswell Park, the human being. The institute's named after him. It's not necessarily a green place. I'm going to start with the slide that Shashi Kumar was very kind to provide from the last ASH. And this is looking at the Mayo survival in patients from 2001 to 2005, and then the improvement from 2006 to 2010. You'll see that the most improvement was in the 65-year-old patients and above, but that the previous 5 years, the improvement had been in the younger patients. So the older patients have caught up, and now we need to come up with strategies that will allow us to improve outcomes for all patients. This is adapted from Heinz Ludwig's article in The Oncologist from last year, so in terms of deciding therapy based on age, comorbidities, staging, cytogenetics, molecular diagnostics. Dr. Munshi will take us beyond that with his talk coming. And then other high-risk features, extramedullary disease, plasma cell leukemia, high LDH. This is data from the French from 2007 showing the influence of 414, deletion 17, and beta-2 on overall survival. The black lines are patients without those abnormalities and a low beta-2. The green line is the same, but with patients with a high beta-2. And the gray line is 414, a deletion 17, low beta-2, and then the pink line is with high beta-2. So you can see that there is a stratification downwards with higher risk features in terms of 414, deletion 17, and here deletion 13 is in the middle, primarily due to the use of Velcade. This is the gene expression profiling and risk. This is the first step. This is from the Arkansas group, and this is comparing a 17 and a 70 gene GEP, which identifies a population of about 13 to 14% for whom total therapy does not work. So these are very high-risk patients. And the Dutch have come up with another molecular panel, which they then looked at, derived it from the HOVON 65 data, and then applied it to a variety of different data cohorts. And we're able to identify about a 20% high-risk patient population for here in total therapy 2 and 3. For the MRC9 patients, here they are separated out by transplant versus no transplant, and from the APEX bortezomib trial. So this may be the beginning of what we think will be another step beyond cytogenetics that will allow us to risk stratify. Interestingly, when they looked at EMC92 and GEP70 patients together, those patients, about a 12% very high-risk patient population for which no strategy seems to work in terms of overall survival. This is also taken from Heinz Ludwig's The Oncologist. The right-hand side is for the transplant ineligible patient in terms of reasonable therapies for induction and then maintenance options. For the left-hand side, usually it's an induction. And as Hari mentioned, we're moving more towards a 3-drug regimen as opposed to the 2-drug regimens, then on to harvest, transplant, and then 3 approaches, either no treatment, straight to maintenance, a consolidation, which has primarily been pioneered by our European colleagues in terms of control of disease, and then on to maintenance. This slide is courtesy from Jesus San Miguel and Bruno Paiva. The idea of depth of response, and it brings up this whole idea of, do you control the disease, or do you try and drive it into best response here by either a molecular or flow cytometric negative detection for minimal residual disease. And this is data from the GEM 2005 study in the younger patients showing that MRD negativity predicted for improved PFS and OS in their patient population after transplant. So this is an important outcome, which I'll mention briefly in terms of the 0702 trial. This is from the MRC9 trial. This is courtesy of Bruno Paiva, and it's Rostrun's data that was presented at the IMW in 2011. It's a little bit busy slide, but these, if you look at all patients who are MRD negative and receive thalidomide, they're here in green. Those who are MRD negative but don't get maintenance are here in blue, and while there's a trend, there's not a statistically significant difference. And if you look at the patients who are MRD positive who receive thalidomide, they're here, and those who are MRD positive and don't are here in beige, and there is a significant difference in terms of PFS. So this would suggest that if you're going to target a patient population, it is those who are MRD positive after transplant. So this slide is courtesy of McCarthy. The ideas and the aims of consolidation and maintenance. Consolidation is to improve the response or induce deeper response by administration for a limited time of more intensive therapy. Maintenance is to maintain response achieved after therapy, and it's for a prolonged period of time, and the overall goal is to prolong survival. This is from the Nordic Consortium, where they looked at a bortezomib after single or double transplant consolidation. Patients were given 3 months of bortezomib versus patients being observed. And what they found was that after bortezomib, they had an increase in CR and near CRs compared to the controls, increase in VGPRs. PFS was slightly improved, but the overall survival was unchanged. And this is a slide also courtesy of Dr. Cavo. This is the Italian study that looked at a vel-thal-dex induction versus thal-dex collection transplant, and this was a tandem transplant. And then a further consolidation with two 35-day cycles of vel-thal-dex versus thal-dex, and then maintenance with dexamethasone. And if you look at the thal-dex versus the VTD, you'll see that there is an increase in near CRs, increase in VGPRs, and there was more stable disease in PRs in the patients receiving the two-drug combination. And if you look at the Kaplan-Meier curves for PFS from the landmark starting of consolidation therapy, you'll see there's an improvement in PFS when comparing VTD versus TD. There is no difference in overall survival. And when they looked in particular at patients who were 414 positive but deletion 17 negative, there's a marked improvement in PFS, although these numbers are small between VTD and TD. And then supporting the concept of some form of consolidated therapy to enhance response. Now, Hari mentioned this earlier, and I'll focus on one part of this, which is the bortezomib induction and maintenance. This is the HOVON 65 trial where patients receive VAD or PAD. I guess they called it PAD because they didn't want to call it BAD. And then they got a stem cell mobilization, and then, as mentioned earlier, a single or a tandem transplant if you were in Germany, and then high-risk patients received an allo. And the VAD arm got thalidomide, and the PAD arm got bortezomib. And these are, sorry, it's hard to see these, but these are the progression-free survival. This is if you take out the allos, or if you include the allos, sorry. And this is the overall survival, which shows a trend towards benefit in the bortezomib arm. And this shows the response data. So in this study, it's hard to tell if it's the induction or the maintenance that improve things, because when you looked at the VAD patients, there were 5% CRs and 11% PAD, and you can see there were more responses in the PAD arm versus VAD. This is after high-dose melphalan. You can see, again, there's an improvement in the PAD arm, and this is the response on maintenance therapy. So you could argue that perhaps that the induction therapy played a large role in the improvement you see in the maintenance outcomes. And this is another very busy slide from Peter Sonnenfeld, who's kind enough to lend these to me, or give these to me, showing by deletion 13, 414, and deletion 17. The most important thing to see is the blue line, which is the VAD arm, followed by thalidomide. And these patients uniformly did poorly, in particular if they had deletion 17. And the red arm, red curve are the patients who received bortezomib, showing that it at least partially reversed the negative aspects of deletion 17p. And I don't have time to show it, but when you also looked at patients in renal failure, you saw the same thing. Patients who got VAD that followed by thalidomide did worse, much worse, than patients who received bortezomib. This is the IFM 0502 study. It's a phase 3 randomized study looking at 614 patients who received either bortezomib dex or VAD, and then were stratified according to these factors, consolidated with 2 months of lenalidomide. and then randomized to either placebo or lenalidomide. The primary endpoint was PFS. This is the PFS from randomization. This is a little bit early, but it's essentially the same curve that was in the publication. And this is the overall survival. Now, this has been debated back and forth, and we can talk about that in Q&A. And I'll be interested to see what the update is from the French group with long-term survival. This is the problem that's also raised a lot of controversy, the second primary malignancies. Interestingly, there's a balance in terms of the AML-MDS, but now they're up to 4 ALLs and 4 Hodgkin lymphomas, which occurred in the lenalidomide arm, a variety of different solid tumors, and it's unclear of the etiology of this, and we can talk about that also during Q&A, and I'll show our results on the 100-104 trial. This is the 100-104 trial. Patients less than 70 years of age, as opposed to 65 in the French trial, receiving at least 2 induction cycles, stable disease or better, within a year of therapy and with adequate stem cells, had a single transplant, stable disease or better, then were at day 100, were then randomized to placebo or lenalidomide. The study was also essentially a PFS study. It was an improvement in time to progression from 24 to 34 months. This is the progression-free survival curve showing the improvement with lenalidomide. Of note, 86 of 128 patients have crossed over at the time of the study on blinding, which has made subsequent analyses a little more complicated. This is the overall survival at the time of the analysis, the Halloween analysis in 2011. We have updated this, and the overall survival still persists, and we'll be presenting the follow-up results of this at the IMW in April, showing a persistence of the overall survival benefit, and we're trying to figure out how's that working even with the crossover. These are the second cancers that occurred on this study. We had 1 ALL, but also 5 AML, 1 Hodgkin lymphoma, MDS, and a myelodysplastic syndrome. So there are a total of 8 versus 1. These are the solid tumors of which there was a mix, and then the skin cancers. When we did a cumulative incidence risk, the blue line here, the cumulative incidence risk for patients receiving placebo. This is the cumulative incidence risk for second SPMs for those receiving lenalidomide. This is the risk of death for the lenalidomide arm, the risk of death for placebo, and the risk of progression for both lenalidomide and placebo. So the risk of SPM is higher for the lenalidomide arm, but the risk of death and progression is higher for placebo. Interestingly, when we did a subgroup analysis, we found the 2 red curves are patients who receive lenalidomide maintenance, and the 2 blue curves are those who receive placebo. For patients who receive len as part of their induction, but then receive placebo, they are essentially superimposable with the patients who received other forms of induction followed by placebo. These are patients who received non-len containing induction and then len maintenance, and these are the ones who received len induction and len maintenance, suggesting that continued exposure to lenalidomide may be most beneficial in terms of time to progression. And we also found a difference in terms of overall survival with the same analysis. These are patients who received len induction followed by len maintenance when compared to the other 3 arms, and this was significant. So I keep getting asked, what is the difference between 0502 and 100-104? So this was just published in JNCCN. And in 100-104, there were about 74% thal and len-containing regimens versus half and half for VAD and bortezomib-dex. There was no consolidation. A quarter of the IFM patients received DCEPT. 20% of patients received 2 transplants. There was no len consolidation in the 100-104, whereas there was 2 months in the 0502. The median follow-up was 18 versus 33 months. Median follow-up from randomization was 31 versus 45. The dosing was essentially the same. Time from first patient enroll was 78 months versus 62. They did their study faster. There was a crossover in 100-104. The French placebo patients did not cross over. There's about a 2.5 to 3-fold increased incidence in SPMs. More AML-MDS in 100-104, not in 0502. We could discuss that in terms of the alkylator exposure because there was a higher incidence in the placebo arm, or is just the same as lenalidomide. There was no increase in ALL Hodgkin lymphoma where there was in the French study, and that's the subject of much investigation as to etiology of that. And they stopped their maintenance at approximately 32 months. Now, we'll talk about that a little later in context of the French-American study. So there was a somewhat prolonged exposure to lenalidomide before cessation. So, moving on, Hari discussed this earlier. This is the Italian study that was shown at EHA. They updated it again. RD induction, MPR chemotherapy versus a tandem transplant, and then no maintenance versus R maintenance, 3 weeks on, 1 week off until progression, PFS, OS. And this is new data. There's no p-value for this. This was also presented in the fall. This is the MEL 200 tandem patients who receive len maintenance, PFS. This is tandem transplant, no maintenance, MPR with maintenance, and MPR without maintenance, suggesting that the len maintenance will improve PFS, and it remains to be determined what the overall survival curves will look like. I put this in, even though this is an auto talk, the idea of consolidation with allotransplant. It's courtesy of Gordon Cook from England. And this is the Bjorkstrand trial, which showed at approximately 3 months, 3 years, an approval in OS for auto allo versus either single or tandem auto. But as you know, there's big controversy because the CTN study was a negative study. So this is another form of consolidation, and this is a courtesy of Amrita Krishnan, who showed this slide yesterday. These are the event-free survival for a variety of different studies, HOVON, IFM, EBMT, of about 28 to 35 months. And in 100-104, the median time progression was 46 months. So a lot of our trials, especially with incorporation of maintenance, have increased the time to progression, and thus strategies that involve allotransplant are going to have to take this into consideration because we're doing a lot better now with auto followed by some form of maintenance strategy. So this is from Paul Gauguin. Where do we come from? What are we? Where are we going? If you're from Boston, this is in the Museum of Fine Arts. So this is the French-American study, which was mentioned earlier. The French arm is closed. They do 1 year of lenalidomide whereas in the American study, it will now be lenalidomide until progression. That study is open and accruing. This is the EMN02 study, and this is a VCD, now incorporating the finding of use of Cytoxan with Velcade and dexamethasone, a randomization to 4 cycles of VMP versus single versus double transplant, and then another randomization to either maintenance until relapse, 3 weeks on, 1 week off, versus a consolidation with VRD, then maintenance 3 weeks on, 1 week off. And this study is a PFS study. It's not powered for overall survival, and still it's a 1,570 patient study. And as mentioned earlier, this kind of study is very hard to pull off except in a multinational large study, and it's still a PFS study. So overall survival studies are going to be very difficult to design just because of we're doing so well with sort of the upfront treatment. This is the BMTCN study, just to reiterate that it's a single transplant, a single followed by VRD consolidation, or a tandem followed by len maintenance. It's almost three quarters of the way to accrual. It should finish sometime next year, and that will inform us as to the role of maintenance therapy, and as well as, not the role of maintenance therapy, the role of consolidation versus single or tandem transplant. This study, led by Marcelo Pasquini and Terry Hahn, is the flow cytometric correlative study. Is going to look at these time points here for MRD, and this is the most important time point because we want to see if we can recapitulate the Spanish data and then look at a time point when you're into maintenance in terms of MRD positivity or negativity. And this will hopefully inform us for future studies. Could we even looking at MRD negative patients to randomize to continued maintenance versus no maintenance? I think most people would agree that patients who are MRD positive are going to need some prolonged exposure to some form of therapy. This is the panel. I'm not going to go over that in great detail, but involves CD38, CD45, and then the 1956, 11720. The thing that's interesting about this is that we've incorporated kappa and lambda, and we think this will be a different approach. The Spanish studies did not, and we think that that may allow us to further refine flow cytometric analyses. The other thing we'd like to do is come up with a standard approach, because as you know, there's a bit of art involved in terms of setting of gates and number of events to be counted. We're counting 2 million events. And we can develop a standardized protocol for this that may allow for comparability between different centers with regards to how we use flow cytometry. The one concern about using molecular is you need diagnostic samples to get primers so that you can do your PCR, whereas this can be done on samples that are non-diagnostic. So we think that this type of analysis will be valuable for us in the future. So in conclusion, I'm early. Consolidation and maintenance are treatment approaches that can improve response and lead to improved PFS, OS, and EFS. The European cooperative groups have been in the forefront of novel consolidation therapies to improve response after transplant. Induction therapy with bortezomib, transplant, and maintenance bortezomib improves PFS and OS in selected patients when compared to VAD induction, transplant, and maintenance thalidomide. Lenalidomide maintenance after transplant improves PFS and in the American study OS, and appears to be most effective in patients, that should be patients, receiving lenalidomide induction. We need to develop new strategies for high-risk patients. It's a major priority. And I'd like to thank participating centers. There were 47 centers that enrolled patients on the 100-104 study from CLGB, now the Alliance, ECOG, and BMT CTN. It was a cooperative group. In particular, I'd like to acknowledge Koros Azar, who developed and statistical design that was just unsurpassed in terms of analyzing and designing the study. My colleagues from ECOG and BMT CTN. And I will stop there. Thank you very much.